The
Prabhat,
first
are
point
you
which
live?
came, yeah. The first point which came was a policy advocacy effort, multi-stakeholder approach. Second, access to information in a form which people can digest. Key to access, unlocking the access program. That is also a very important point. Life cycle approach, as Vijay said, it's the whole life cycle approach. Equity in healthcare. It is not only about access, but also equity in that healthcare, access to clinical trial. And there are many, my whole note is there. I will note it down and share with each one of you. Now, before I end, I just want to put this slide of Mahatma Gandhi saying that the future depends on what we do today. What has happened in past, what will happen future, but I think it has to have a start. And I think a lot of important points again came together with this diverse set of people. So definitely it will shape future. And I think together this whole group have been working at various forum and it will continue to do so. So with this, I hand it back, Dr. Amol, to you. Apologies for crossing some time limit, but thank you so much to the chair of the session, Dr. Amol.
Yeah. So thank you, Prabhat, for covering the many of the aspect, and thank you all panelists for giving their valuable opinions. They have shared their experience. Uh, what I see is we have a great future ahead. This is just a start. I would say that we are just scratch it. We have to do lot many things in coming days. So we are just woken up from the sleep. Just I would say that. So there are multiple issues, like Vandana ma'am has said that the patient voice, the doctor should listen to them. I would say here one thing that it's a very, very complex and a heterogeneous issue for cancer treatment as such. So every day there are new approvals. Every day some new science is coming up. There are various armamentarium are getting developed. For 10 years ago, we were not aware about immunotherapy. And these days, you find each and every cancer drug or the old chemotherapies have been combined with the immunotherapy. Newer research has bring in the TKIs, which are these immunotherapies and TKIs are beyond our control of the price negotiation and all. So my point here is, along with the patient advocacy, yes, there is always a big problem, as Dr. Pallavi said, that the communication. Like when I was giving a lecture in one of the cancer awareness program in the Adivasi district of Maharashtra, that is the Nandurbar, wherein a very active BHMS doctor who has practice in the gynecology, and she just catch me during the conference on one point. She just stand up after the lecture and she said, how do you control over the loss to follow up, and how do you pick them these people that they have to come back again? The moment you say your pap is been done, that is pap smear has been done, and next day what happens is, what is going to test? When you say that it is cancer, 90%, 80% of the females will not turn. Then I come to one idea that, can we change the cancer name to chronic proliferative disease? So at one end of our community where we have this kind of a problem, so patient education, that's what an integral part of any patient advocacy is. Basic starts, as Dr. Pallavi says, what language they are understanding. So this is a very basic thing we have to start, and it needs to be at an education level. So we might have to tell the government that or the basic education, like the CPR is taught in 10th or 12th grade in United States, and it is a mandatory kind of a certification for everyone. The school nurse teaches them. Why can't we have such kind of a facilities where we tell that this cancer is a curable disease? There are many kind of a treatment available, so that the fear goes off from the day one. So that is one problem I see. I would like to ask many questions also, but for Dr. Vandana, I have one question, if you don't mind. How the budget you take for the costly drugs, how much you go, like 10 lakh, 20 lakh, 1 crore, 2 crore, in case it comes to you to fund or the support the patient from a company or whether any NGO?
So the access programs that we are doing with the pharma companies are all supported by the pharma companies. Our role is to assess the patient and see whether the patient falls into the category of getting the free drugs or not. And if he does fall into that category, then the entire treatment is done free of cost till as long as the patient needs it or is alive, unless the medicines are changed.
So many of the new drugs are not given free of cost or from the compassionate access, except when the crizotinib came. Otherwise, I am not aware that any of such medicines is available. I think the Prabhat is also nodding that, and there's a very difficult time ahead for the NGOs to bring such costly medicine, even for the companies. So that is why here comes the role of the work done by our Tomar sir. So Tomar sir, are you still logged in? Vivek sir? Anyway, on so you have given us a kind of a very big, in fact, when I say it is a patient advocacy, or if I say any father of a clinical trial or a research in future days, I'm going to take your name, because you are the one who has started this, and this is the most important aspect of any country. In fact, it's a very sad part that when I was presenting in one of the forum that is known as TOPRA in New Delhi, it was European, Australian, and Indian collaboration work, wherein the executives talk about the policy issues, governing issues, and in that conference, I could realize that why alectinib. I asked the question to one of the company representatives that why the alectinib trial did not come to India. It was sad part that the China did it, the Japan did it. There were 400 patients, 300 patients from China, 100 patients from Japan. Why did this not came? So the lady categorically said when we launch a trial, there is a time frame. So around 5 years back, the China and we were together in the policy making decisions, and the clearance from the higher headquarters, whatever you say, the ICM or the ministry. In India, from 2 years time, they got it down to 14 months, and then they brought it down to 12 months, and then they have got it to 9 months, because I was just telling her that, "Nay, we are doing good job." But then she said, in China, now the time is 3 months. So for any patient advocacy or the doctor advocacy, there are a lot of still road, there are blocks on the route. We need to really bring this point at a national level. The politicians, now our health minister, she is herself is a dermatologist. If we approach her, the deputy health minister, and tell her that this is what the issues are there, and Prabhat, you can take this lead here and collaborate with the other companies that how can we fast track the things. This is no more this is no more is we're going to accept this. So we have many challenges from the patient education till the implementation of the clinical trial. Now I'm coming to Vijay ma'am. I always see her a very good Twitter post, right from her personal experience in life, and so many, right? She enjoys a basic thing like rain. She must just put a photo of rain, and then just a small photograph of a flower. Anyway, so here, ma'am, you have worked extensively for CML. My point here is very simple. In fact, one of my patient, when he asked me, doctor, for my mother, what should I do? His mother was ALK positive lung cancer. So when the data was emerging in 2018 or 17, that time I asked him, being in Forge, I can't do too many things involved in the NGO and all, but I gave him the idea that you come with the ALK Society of India. Let's start your work. So we have lot of work we have done as a country in CML. N number of patients got benefited. And when I say it's CML and compare the ALK positive, ALK positive lung cancer is a new CML. Last year, the lady who first participated in the lung cancer trial for the ALK positive with the crizotinib, she has crossed 14 years now. So this is the importance of clinical trial, wherein the patient gets the opportunity to get the treatment as earliest. Now, the alectinib, which is considered as the best medicine for the lung cancer who are ALK positive patient, the life is going in such patient beyond 8.5 years. It is unheard of. It is unheard of in oncology. In a metastatic setting, we are talking about. So as your organization or the other organization, can we, from this forum or the patient advocacy and our doctors group recommendation, Chittelkar sir's organization, can we take this lead and make some avenues to get the best of the best medicine for such kind of patient from government? Let's take it as a state responsibility. Yeah. For certain curable, which is a disease of young India, which is a young, whatever you say is a 20 to 40 years. We don't see ALK positive in 80 or 90 years or 70 years. It's predominantly a disease of a young adult. So why don't we take a lead here and tell the government to negotiate the way the NHS functions, the way Health Canada functions? क्या भाई इंग्लैंड अपने देशवासियों को दे सकते हैं और 2000 अल्क पॉजिटिव लंग कैंसर को क्या हम महीने की 50,000 या जो भी नेगोशिएशन आप करेंगे, and I am sure the Roche will be ready to negotiate with the government if they are giving such kind of a beautiful medicine to each and every patient of India. Everyone is going to help. What is lacking is, I recently came to know that the drug pricing doesn't come under the purview of the either ICMR or it is the health ministry. Nobody knows how to do the CADET is the organization in Canada which decides how much dose is to be given, how much cost can be considered by the government. So such kind of a points, I believe we have to take forward one by one. There are diseases to come. And for Vijay ma'am, I have a special request through this conference. Your next target should be for this ALK positive lung cancer in India, because I feel the mechanisms of resistance, what we call in CML, exactly such kind of point mutations are there in this kind of a cancer. And if there are mutations, some new drug is coming. I think we have already crossed the limit, but I just have to tell another point here is which I have always realized the logistic as a big problem. So 1 week back, I had one patient of exon 20 insertion mutation, again a lung cancer. For that, there are 5 sites in India, the enrollment clinical international trial, that is amivantamab. And patient visited the prestigious institute in Maharashtra where there was a trial was going on. After seeing the lot of the crowd around, they just lost in the sea of patients, and they came back to me again and they said, "Doctor, whatever you do, please do it in our hospital." And I'm sure these are the things patients do suffer. As I have read Chittelkar sir paper on how to improve the access, wherein the patient's follow-up is going to improve. The abandonment rate can decrease in a coming time, that we have to pursue our treatment and get them on the board. So this logistic issue, I feel is one of the very, very critical thing, and organization like TYAcan they are there in country. So this is a complex issue which also needs to be addressed. Prabhat, we should also think about this, how to deal with such problem. So with this, I think मैं आज रात भर भी बोलता रहूंगा तो मैं बंद नहीं होऊंगा सुबह के 4 बजे तक. So oncology is my passion. That's why I always say I thank Dr. Palvi, Dr. Vandana, Vijay ma'am, Tomar sir. Everybody has done, and even and I should not be forgetting Alpana madam. So she, in fact, she has the again, as like Tomar said, she has done the initial work or the founding work for getting the rare molecules to the patients of SMA. Once again, I thank you all the panel members. I hope such kind of meeting will be a regular event in one of the national conferences. I will put this point to the ICON and the ISMPO also to kind of consider such kind of a conference. Whenever the medical conference is there, this should be an integral part of the curriculum for everybody actually. So what patient desires, what patient want, and where are the problems is. So with this,
I would like to, especially because, sir, you made this point, I would like to say that you're very right. The two most important stakeholders are, of course, the government and the industry. And without their support, non-profits are not able to do anything at all. And we will constantly be, striving to make sure that we encourage pharma companies to continue with their humanitarian donations, because that is how the Max Foundation runs various access programs for various cancers. And without that support and without an understanding government, without a government should not look at a non-profit or an NGO as its enemy. The government should look at the non-profit as someone who supports them. You're right, we don't have the kind of service that NHS provides in England or the Canadian. Here, of course, health is a state policy. There's not even like a consolidated central policy for health. So these are the challenges we face, and it is the cost of these targeted therapy medication, which is totally crippling. That's exactly what Vivek also said, and we are struggling. But I like to think also that if we keep positive, if we balance all that with positive thoughts, we encourage the patients, we empower the patients, and we become the effective bridge between the treating physician and the patient. We work as a team. And I think we should conclude on this very positive point that yes, the healthcare professional, the medical fraternity is giving now a lot of respect to the non-profit. They understand the role that NGOs play. And I think we can stop on that really positive note, because if you don't think positive, then, you don't go ahead.
Thank you. Thank you, Vijay, and thank you, Amol, for conducting this session so wonderfully. And I'll thank all the panelists, Alpana ji, Pallavi, Dr. Pallavi, Vijay, of course, Vivek Tomar and Dr. Vandana, madam. Thank you very much. And we close for the day. Please do attend the TYAcan Congress, which is the next 2 days. And I'm sure similarly exciting topics will be discussed there, and you'll enjoy the scientific program. Thank you very, very much, everybody, and good day.
Thank you.
Thank you. Thank you.
Thank you. Thank you so much.
Thanks.